Hi, everybody. It's me, Dr. Kevin Stevenson. You join me on I Don't Care with, again, me, Dr. Kevin Stevenson. And I feel compelled about every 8 to 10 episodes to explain the name of the podcast. I Don't Care has been around now. We're coming up on 4.5 years. Hard to believe, right? And thanks to everybody that subscribes to the podcast. And really, I welcome all you new folks joining us. But I Don't Care came about when I was talking with one of my friends. They said, "Hey, I've got an idea for your podcast name." I said, "Okay, what is that?" They said, "I don't care," and I kind of looked at them. I had some trepidation about that. And they said, "Well, look, you're not a direct patient caregiver, so I don't care." I said, "Okay, I kind of get where you're coming from now." So just to let you know, I really do care, but I don't physically provide hands-on care, but I support thousands of people who do. So that's a little bit about where I Don't Care came from. So today's guest today, I'm very happy to be joined by Dr. Nancy Klotz. Dr. Klotz is the Chief Medical Officer at Brighton Health Plan Solutions. That's a healthcare enablement company based in New York that helps purchasers of group health plans and their members avoid paying too much for healthcare. And don't we all want that, right? Brighton Health Plan Solutions provides self-funded clients, health systems, and TPAs with the tools they need to enhance their member experience and offer highly customizable plan designs with ultimate flexibility. And don't you, as a podcast host, don't you like when people send you a wonderful intro like that I don't have to come up with personally? So Dr. Klotz, welcome to I Don't Care, and thanks for being on the show.
Well, thank you, Kevin. I'm delighted to be on your show. Thank you for having me.
Absolutely. Hey, tell my audience a little bit about your background and your role at Brighton Health Plan Solutions.
So I am an internist by training, and I have over 30 years of training in medical management, working in a variety of companies for Medicare, Medicaid, and commercial lines of business. I've been with Brighton about 3 years, and I basically oversee the medical benefits, the plan design, the utilization management, case management, population health and wellness programs within Brighton.
Very good. I know that's a huge job, but we're going to try to focus just on one area today, and that's on the obesity epidemic here in the United States. So, can you share a little bit about how large that problem is and about weight-related health conditions here in our nation?
Well, definitely. The number of people experiencing obesity is certainly increasing. Since the NIH, that's the National Institute of Health, started measuring obesity rates about 60 years ago in the US, they have tripled. More than 42% of American adults are considered obese, and that's a BMI, a body mass index of over 30, and a further 31% are overweight. That's a BMI of anywhere from 25 to 29.9.
Okay.
Since
That's incredible.
it's even more incredible because since excess weight is linked to so many chronic conditions, diabetes, hypertension, high blood pressure, congestive heart failure, heart disease, sleep apnea, osteoarthritis, healthcare providers are looking for long-term solutions to reduce patient risk. And the organizations we work with are hyper-focused on helping their employees or members stay healthier. But at some level, they have to look at the costs and benefit, the risk-benefit ratio for treatments that address obesity that could possibly help their patients avoid chronic illness. Reducing obesity rates is a good way to avoid future chronic illness because excess weight is linked to the development of so many chronic conditions, especially cancer. We have breast cancer, colon rectal cancer, endometrial cancer, gallbladder, kidney, liver, pancreatic, stomach cancer. All these are worsened by the presence of obesity. So, for a lot of reasons, companies want their employees healthy. And chief among them is to help them avoid missing work because of illness or ill health and to prevent expensive and disruptive hospitalizations and other treatments. It's always been a challenge, difficult and expensive to change and maintain the trajectory towards reducing obesity. It's one of the most difficult conditions to treat It's mostly because it's a behavioral and lifestyle change modification that's required, and along with whatever other treatments, including some of the medications we use today
Mhm.
for treating obesity. And
Well, and I'm going to say, I fall into this category. So you've gone from preaching to meddling, how we say it down here in Texas. And so, but anyway, yeah, and you're right. I mean, so many chronic conditions are linked to obesity. Fortunately for me, regardless of how I look, I'm in really pretty good health. So I'm fortunate with that. But I do suffer from diabetes. And
mm,
so, let's talk a little bit about, the chronic diseases, particularly diabetes, and how big of a problem that is for health insurance and self-insured health plan sponsors.
well, it's a huge problem. First of all, if you suffer from diabetes and also have obesity, you potentially could have a condition called metabolic syndrome, which, along with high blood pressure, hyperlipidemia, all these bad chronic conditions together increase morbidity and eventual poor health outcomes. Diabetes, in and of itself, is uh, there is a huge market and all sorts of types of treatment for it, but it has a lot of negative sequelae as well: vascular disease, kidney disease, blindness, retinal disease, including heart disease. So obesity makes diabetes that much more difficult to manage. In fact, that's why these drugs were developed in the first place, because they were first developed to treat diabetes, and then secondarily it was discovered that some of them are also have the side effect of obesity management as well.
Yeah. Well, let's talk a little bit about how, health plans should respond to the the recently the recent FDA approval of some of these diabetes drugs, like you briefly mentioned, that have been effective at reducing weight. Hey, I'm a Manjaro guy. I get it. So let's talk about the struggles of treating obesity historically. You know, you mentioned a little bit about why it's so hard because again, you've gone to meddling. You're talking about you want me to cut out my barbecue, my chicken fried steak, everything that I love. I'm all about we're all about food and cream gravy down here in the South.
Okay.
So why is it so it's so multifaceted trying to treat obesity, correct?
Yes. I, it, it's because it's a multifactorial treatment to get
Hmm.
obesity under control. It's diet, it's exercise, it's a lifestyle change. So you can't just give a drug and just walk away. This is something that for the rest of your life you would be struggling with. In fact, there is some theory that folks have a set point. So even if after you've lost weight or been successful at a diet, your body tries to bring you back to the point it was for years before you started that diet. So this behavioral modification, all of this is part of the management of obesity. And even patients who are often successful at losing maybe 5 or 15% of their weight, they bounce back. And that is basically most of the problem. And we have a lot of incentives to go for your chicken fried steak. I happen to love bread. We all have our loves. And food, by the way, is not just um, a method of staying non-hungry or satiating oneself. People use food for all sorts of reasons, including behavioral reasons and emotional reasons. And in
Sure.
those cases, it's even more difficult to manage.
Oh, you're right. I mean, hey, it's socialization. I mean, you get together with friends to do what? Go eat. Let's go eat. Let's
Or
go have a
drink,
glass of wine.
and you
Yeah.
have a few calories.
Yeah.
And weight
Absolutely.
loss surgery also is problematic, even though it's not a magic pill either, because even though it
Hmm.
may be successful, that's also lifestyle modification. Folks have to eat differently. They have to
Right.
work at keeping the weight off, and there are complications with these kinds of surgeries as well. It's still
Yeah.
surgery at the end of the day.
Yeah. I've got a family member that's had weight loss surgery, and unfortunately, they've gained most of that weight back because they didn't. Yeah, I will say they didn't have the adequate pre-surgical you know whether it be behavioral modification or things like that. They didn't really have that. So, they went in thinking the surgery was going to be a magic pill. Hey, I'm going to lose 100 pounds and life will be good. But they didn't really recognize that, yeah, it is a total lifestyle change that's going
Exactly.
to follow you the rest of your life.
True. Very true.
So, so let's talk a little bit about these new drugs, the Monjaros, the Ozempics. Hey, I'm not getting paid by them, but I'm just throwing those out there. Let's talk about how they work, and some of the side effects too that they have.
So, given what we've just talked about with historical treatments for obesity, the barriers for insurance coverage to address obesity as a chronic condition have been high. And part of that barrier is that these drugs are quite expensive. So Eli Lilly produces Mounjaro, which, if you want to know the generic name, it's tirzepatide. It's actually a combo drug. It's two different drugs, a GLP-1 agonist and a GIP, for those who want to know. And Novo Nordisk produces Ozempic. Trade name for semaglutide, which is a long-acting GLP-1. And when they hit the market to fight diabetes, they achieved impressive weight loss, especially for diabetics with obesity. So they became a second or third line treatment for diabetes for those diabetics who have heart disease, a very high hemoglobin A1C, which is your blood glucose level, um, or those with obesity. And they were only recommended for use with along with their usual drugs like metformin and so on. But now we have Wegovy. Novo Nordisk produced Wegovy, which is kind of a high dose version of Ozempic, and it's the only drug officially approved for weight loss in non diabetic patients. But there are a lot of people who use off label, meaning it's not approved, but somehow they get the drug. They use, again, Mounjaro or Ozempic because they have been known to have a higher weight loss effect. So they use them off label to accomplish significant weight loss unrelated to diabetes treatment. You should, by the way, know the higher the dosage, the greater the chances of side effects with these drugs. So you have to be very, very careful. And in fact, um, these drugs could potentially cause thyroid cancer, um, a type of endocrine cancer with thyroid in it, pancreatic disease. People with kidney disease shouldn't be taking them. There are many side effects um, that we need to be aware of when they take high enough dosages, as well as the usual GI stuff, which is nausea, vomiting, constipation, and so on. Um, and now in the FDA, we have another new drug called Zepbound, which is a version of Mounjaro. By the way, these are, except for one of them, they're all injectables, once a week injections, the long-acting ones especially. So some folks may not be eligible to take them. They just can't handle the injection part of that.
Oh,
Um,
that's the easy part for me. I only have to do it once a week. I love that.
that's true. That's true. But some folks just can't handle it, and some folks can't handle the side effects. But these are all, if you want to get technical, called GLP-1 receptor agonists. They mimic certain hormones in the body. Their main effect is that they promote production, they're incretins. So they promote production of insulin, as well as at the same time they delay gastric emptying. In layman's terms, that means they slow your GI tract. So food passes more slowly, you're full more. So because everything is slowed down, so patients who are on it don't have a desire to eat because they feel full for longer and they're
Oh
not.
my gosh, you have just hit the nail on the head with me. Yeah, hey, my audience knows I'm an open book. I started with Ozempic, and it was fine. It really didn't do a whole lot. And then my PCP said, I really want to put you on Mounjaro because, yeah, I'd made some strides in my A1C, but not as much as what he wanted. And so put me on Mounjaro, and I had a sister-in-law that got on Mounjaro. She lost 40 pounds like that. And so I'm thinking, hey, I've got the magic bullet, right? So I started taking. I'm like, yeah, I lost about 2 or 3 pounds, and nothing much happened. But then, yeah, I started feeling full. I couldn't eat. I could eat like a third of what I used to eat, but I still wasn't losing the weight that I thought. And then, literally about 2 months ago, it seemed like it kicked in. Now my weight hasn't changed drastically, maybe 10, 15 pounds, but I've got people coming up to me daily saying, "Oh my gosh, what are you doing? You've lost so much weight. I ran into a friend I hadn't seen in 2 months. She said, "Holy cow!" And I'm like, I'm not noticing that much, but evidently it seems to be working. But yeah, the feeling of being full, it's getting to the point now that I'm looking at my wife when we would go out to eat. And I'm saying, you know what, we probably ought to just split an entree because I'm going to eat a third of it.
And
So
that's the secret to its
yeah,
success.
yeah.
But again, along with that, maybe selection of the right food to eat should accompany this. So if you're
Chicken
going,
fried chicken is still chicken fried steak, right? Right? Am I
well,
right?
you want to have a nice balanced diet that
Sure.
meets all your nutritional needs at the same time that you're
Sure.
achieving the. And also, they do say that sometimes muscle mass might be an issue, loss of muscle mass. So you do want to. They do recommend doing limited, what is it, 150 minutes a week of cardiovascular or some weights to make sure you maintain your muscle mass. So there's a little bit of work involved, but definitely the early satiety is a very big thing, especially you should know that many diabetics have this kind of issue without the drug, so it uh, almost doubles the effect. So, they do have slow gastric emptying anyway, and this will just make it even more so.
Okay. Hey, let's talk about another intervention that I've just gotten involved with really over the last month is I got a CGM device. I have a Dexcom. And let's talk about that with, health plans paying for those and really the effectiveness of those. What do you think about that?
Oh, they have value. They're really very
Yeah.
helpful. I think they're continuous glucose monitoring for those folks who may not know. And remember, when we treat with diabetics with drugs or insulin or whatever the case may be, we're trying to mimic what the body's already doing. And the best mimic is to have continuous monitoring and continuous small dose adjustments. But folks can't inject themselves 10 times a day. So what they do is you oftentimes they use it in type 1 diabetics where good control is important. But they do have excellent value, and there's a variety of different machines out there that achieve those goals. Especially, insurance companies normally would cover them for those people who are difficult to manage, who have ups and downs throughout the day, and despite being on a regular diet, a regular dosage of medications can't manage, or for those who have some of the side effects of diabetes, like reactive hypoglycemia, early morning hypoglycemia, where their sugars just vary so greatly that a continuous monitor would help regulate that a bit.
Yeah.
It's important.
Well, I know for me, it's been really interesting, and I've kept it in range. I've been kind of proud of myself, got to admit. But it's been interesting to and I'm one of those. Yeah, I'm an app nerd. I like to look at my app. I'm the guy that checks their bank balance 10 times a day, and now I'm checking my glucose 10 times a day. But I'm able to watch the graphs and going back, it's like, okay, I see at lunch, yeah, it went up a little bit, then it dropped off, and then I snuck that Snickers bar in there. Don't judge, but I snuck that Snickers bar in there, and it didn't go up as much as I thought, so it hasn't made me stop. But things like that, and I've got to be honest, it's really been helpful for me, and I think that's part of this whole weight loss journey for me as well.
Yeah, no, it is. And sometimes you'll see some of the kids be on insulin release, these machines that
Yeah,
release insulin along with the CGM, and they achieve that steady state because they are the most difficult population to manage. And,
yeah.
and type 1 diabetics tend to have a little bit more of an aggressive form of the disease.
Okay. So, kind of what do you think long-term insurance companies covering things like the GLP-1s and the continuous glucose monitors, are they seeing the benefit long-term of those?
It's You have to understand it's still relatively
Mhm.
new on the market. So CGMs are more accepted now. They're not as new, but I can tell you that we are advising employers and benefit administrators to approach obesity like any other chronic disease that requires long-term treatment and maintenance. This is a lifelong treatment, and at the end of the day, employers and plan sponsors must balance clinical and financial outcomes. And to provide the most benefit, many physicians are now prescribing these weight loss drugs, in addition to the weight management programs that include nutrition, educational, lifestyle changes, and behavioral health. These are long-term treatment options. Nothing, if folks are on it for less than 20 weeks, it doesn't work. Most of the studies say that you have to be on it for at least 68 months. 68 weeks. I'm so sorry. 68 weeks, about 2 years, a year and a half. So for it to work and not to bounce back immediately. And it's a lifelong treatment, and it does help the overall long-term options, but that requires companies to invest in long-term health benefits for their members. They are interested in improving the health and wellness of their population, but that mindset, I think, is slowly changing. And given the clinical trials that show the benefits of these drugs, especially reducing the risk of cardiovascular events, heart attack and stroke, are reduced by the use of Manjaro, for example.
Yeah, that was one of the things my PCP mentioned. That and again, I'm in relatively good cardiac shape, but I am getting older, and he was very insistent upon the effects that Mounjaro provides.
Yes, yes, and
Very
especially
good.
diabetes does have that side effect.
Yeah, sure.
So the clinical case for covering the weight loss drugs, at least for certain populations, is more compelling than ever.
Very good. Okay, hey, last question. So when customers ask you for recommendations on coverage, what do you tell them?
Well, they have to go according to their health plan. But if they have diabetes, then it's definitely covered. If they're non-diabetic but do want to work on these drugs or use these drugs, they have to have a BMI of over 30 or BMI of 27 to 50 to 29.9, in that overweight range with one of the comorbidities. I do tell them that in the future, probably these requirements will be loosened up a bit, perhaps expanded, as we see more and more benefits with these kinds of drugs.
Very good. Hey, any last words, Dr. Klotz?
So I just have to say I'm very impressed with your management of your disease. You're very savvy as to control of your disease, and I think that I wish every patient was as knowledgeable and motivated as you are. It would make our jobs as physicians that much easier.
Well, I appreciate that. I don't know how motivated I am at 3 o'clock in the afternoon when that Snickers bar hits my hand, but
Okay,
I'm trying. I'm trying.
and that's all we ask. And
Okay.
very impressive.
Well, it's been a real pleasure having you on today, Dr. Klotz. Thanks so much for joining me on I Don't Care. All right, folks, that's a wrap for today. You've enjoyed my conversation, I hope, with Dr. Nancy Klotz, the Chief Medical Officer at Brighton Health Plan Solutions. That's a wrap for us today on I Don't Care with Dr. Kevin Stevenson. Thanks so much for joining me, and I'll see you next time. Take care.